Good morning. Thank you so much for coming to the Epilepsy Awareness Day at DeZan. I'm Susan Lautenbach. I'm one of the board members here for this great event, as well as part of Lundbeck Pharmaceuticals as an account manager in San Diego and Orange County. It is with greatest pleasure that I get to introduce Dr. Sazgar. She is at the University of California, Irvine. She's an associate clinical professor of the Department of Neurology.
I'm a clinical professor.
Yeah.
A full clinical professor.
I'm sorry.
Your information is very old.
No, it's ready. Associate clinical professor. I apologize. A little nervous because we're running a little behind too, so I apologize for that. But associate clinical professor of the comprehensive epilepsy program here at UCI. And and the topic today for Dr. Sazgar is caring for women with epilepsy treatment challenges. I hope you enjoy her talk. Thank you very much, Dr. Sazgar.
Thank you very much.
Sorry about that.
Thank you everyone for attending today. I am sorry we are late. I don't know what happened to the first speech, but here we are. And yes, I am actually a full clinical professor, not an associate. My passion is women with epilepsy, and that's what I'm going to try to do. This is going to be very jumpy. Let's start with a case, a patient that I treat. This is SB, a 28-year-old woman with a long-standing history of focal epilepsy. So she has partial epilepsy that comes from the right frontal area, and it's due to some abnormal brain tissue in that part of the brain. She used to experience clusters of seizures a couple of days prior to her menstrual period, and then it lasted throughout the menstrual period, and some of the seizures progressed to generalized tonic-clonic activity. In the past 2 years, she's been stable, seizure-free on oxcarbazepine, 900 milligram twice daily, and did not report any other seizure recurrence. So, happy story so far. Oh God, I wish they had just let me see whether this works. Yeah, I'm gonna use the arrow. So, she was put on folic acid the moment that she started dating. So the neurologist said, well, if you're sexually active, there is a possibility you may become pregnant. So let's just start you on folic acid. She got married last year and is taking a birth control pill, which is a combination of estrogen and progesterone. She comes to a neurologist's office and informs her that despite the pill, she's pregnant. And the pregnancy test has come positive. So now she has a ton of questions of what has happened and what to expect next. She experienced 2 episodes of her typical aura, now after being seizure-free for a couple of years, and she's worried, has many questions regarding the reason for contraceptive failure and the seizure recurrence and the effect of the medication on the baby and other future directions. So that is why we are discussing women with epilepsy. Women with epilepsy have a number of unique challenges based on their gender. These challenges start from the time of puberty, from the time of menses, and continues to issues regarding birth control, regarding conception, pregnancy, childbirth, childcare, and all the way to menopause. My talk is going to define what is catamenial epilepsy, the epilepsy that fluctuates with the hormones. I talk about infertility, sexual dysfunction in women with epilepsy. I talk about oral contraceptives and seizure medications. And then I move on to pregnancy and epilepsy, some use of the seizure medications during pregnancy, the benefit of folic acid, and also some talk about the breastfeeding. We all know epilepsy affects about 1% of population. No matter where in the world you are, 1% have recurrent seizures or epilepsy. So that adds up to about 1.5 million women of childbearing age in the United States. From this population, 24,000 give birth each year. When they sent 2 surveys to the healthcare professionals, people who were dealing with women with epilepsy, people who were dealing with people with epilepsy, they had no idea, a whole lot of them, that the sex hormones can change the excitability of the neurons, the excitability of the brain, that there are certain issues that are related to the hormones in women with epilepsy. They didn't know which medications are going to fail, to make the birth control fail. There was a whole lot of lack of knowledge. So it is important to educate not only the public, but also the healthcare professionals regarding these specific issues with women with epilepsy. You may or may not know that the presence or absence of ovulation can affect the likelihood that someone can have a seizure, some woman can have a seizure. Seizures are linked to the menses because the sex hormones, these are active neuroexcitatory agents. So the estrogen and progesterone can actually change the excitability of the brain cells. Now, estrogen is the bad hormone. That's the one that can increase the frequency of interictal spikes. So if you do EEG, around the time of a spike of estrogen, you'll find more spikes, sharp waves in the brain, and then also more frequent seizures. Progestin, on the other hand, is the opposite. Progesterone is a good hormone. That's the one that protects against seizures. So how would that play into our body? The seizures work through, like their effects on the sex hormone is through the structures in the brain that we call HPO axis. So there's hypothalamus, one of the centers. There is a pituitary gland, the anterior pituitary, and they release chemicals that go to the ovaries and make the ovaries produce estrogen and progesterone. So all these LH and FSH, all the names that you see up there, these are precursors of the sex hormones, and the seizures may interfere with these structures in the brain, and that's how they affect the amount of sex hormones. They may change that. They may cause change in the fertility in a person who has epilepsy, in a woman that has epilepsy. Specifically, there is a structure deep inside the brain, deep to the temporal lobe, called amygdala. Amygdala is the center of our emotions. All our fears, intense emotional issues that we have, they all come from that structure. Interestingly, that's the same structure that is very much involved in epilepsy, in medically refractory epilepsy. In patients who have temporal lobe epilepsy, if we remove the amygdala along with the temporal lobe, we have a higher chance of making that person seizure-free. So amygdala is very important in producing seizures, and removing that can be helpful in helping patients with epilepsy. Now, in animal models of epilepsy, when they stimulated the amygdala, they actually could create anovulatory cycles, the menstrual cycles that the rat was not ovulating. And also, it could induce development of cystic ovaries. So you have a structure that is very active with seizures in a woman with epilepsy, that activation of that through the same HPO axis, because amygdala has connections to the hypothalamus, it has connections to the pituitary gland, to all those structures that produce sex hormones. So when it is abnormally activated, when it's stimulated during a seizure, it can cause changes in the sex hormones through that reciprocal branches that it has with the rest of the brain structures. So you see that seizures can have effect on the sex hormones. They may affect ovulation. They may result in lack of ovulation and infertility. And that's why the rate of birth in women with epilepsy is about 1/4 to 1/3 of the general population compared to all women who are sexually active and who are in their childbearing age. Now, AED in my slide stands for anti-epileptic drugs, so the seizure medications. What are the effects of seizure medications on sex hormones? That's another thing. So we are talking about the seizures and the seizure medications affecting the sex hormones. Seizure medications can contribute to sometimes pituitary hormone abnormalities. So there are some medications that cause elevated prolactin. There are some medications that disrupt the pituitary hormones. and they can cause abnormal concentration of the sex hormones. So it's not just the seizure medication can also make that disturbance in the sex hormones. Then there is more reproductive endocrine disorders in women with epilepsy. Polycystic ovary is one of them, sexual dysfunction, and unfortunately, early menopause. That's another thing that can happen in women with epilepsy. In their early, like mid-40s, they start in 45, 46. That's the age that a lot of women with epilepsy undergo menopause. Not only it causes an ovulatory cycle, the epilepsy, it also, as a result, can cause worsening of the migraine. It can increase the emotional disorders, increase the rate of reproductive cancers, and also greater seizure frequency. Basically, the reproductive disorders occur in about a third of the patients with primary generalized epilepsy. That's the type of epilepsy that is more genetic. Both sides of the brain, they activate at the same time, so that's the primary generalized. So it is much more common to have reproductive disorder in that type of epilepsy as opposed to focal epilepsy, when you have a part of the brain that is starting the short circuit, starting the seizure. About 15% in that population have reproductive problems. What are the signs? What do we look for? A physician or a woman who has epilepsy should look for any of these signs that can clue into the possibility of endocrine problem. Weight gain greater than 10% from baseline, increased body and facial hair, scalp hair loss, menstrual cycles that are either less than 23 days or more than 35 days, menstrual cycle variability that are more than 5 days from one cycle to the other cycle, and also mid-cycle bleed or disorders of sexual desire and arousal. So all of these can clue in there is some endocrine problem in this woman. Back to what is the definition of catamenial epilepsy. So catamenial epilepsy defined as when pattern of seizures fluctuate with the menstrual cycle. There are three patterns of catamenial epilepsy. The seizures may increase at the time of menstruation. That's when both estrogen and progesterone drop rapidly. That's when the bleed happens. That is the reason for worsening of the seizures at that point is a decline in the progesterone. Seizure also increases at mid-cycle. That's when the ovulation happens. That's when you have a surge in the bad hormone, estrogen. In that case, that's what those women have worsening of their seizures. The third population would be the ones that don't ovulate. They have an abnormal ovulation. Then the entire 2 weeks from the time of ovulation to the time of menstruation, they can have worsening of their seizures. So a woman knows when the seizures worsen. Is it the time of menstruation? Is it the time of ovulation, which is usually 2 weeks before menstruation? Or is it the entire second half? And based on that, you know which category you belong to. In about, how big of a problem is it? About 33 to 39% of people, of women that have epilepsy can have catamenial epilepsy. There are some series that they report up to 75% of women with epilepsy can have some sort of catamenial. So how do we diagnose, and this is again another chart showing the ovulation. That's the mid-cycle, and you see the surge in the estrogen, and then the time of the menstruation when the hormones drop, and the progesterone especially drops, and that is the worsening of the seizure. My patients, the way that they determine whether they have catamenial epilepsy, they use either the ovulation kits, that can be a daily urine test in the morning, the first urine, they test it, and they find out from that ovulation kit when they ovulate, and then they chart the time of their menstruation and the frequency of their seizures. If they have a cluster of seizures more than twice or 3 times compared to the baseline, around the time, a certain time of either ovulation or menstruation, they have catamenial epilepsy. That's how we make the diagnosis. Okay, the treatment of these people, other than you have your regular seizure medications, just like anybody else, we try to target the time that seizure cluster happens. So at that time, you can use medications such as acetazolamide or Diamox, clobazam or Unfi, that's another medication that can be used. Or sometimes we can do progesterone lozenges, progestin-only tablets. There are certain population of women with catamenial epilepsy that can respond to that. So something like Depo-Provera, progestin-only tablets, those kind of things, or progesterone lozenges. Those are the kind of combinations that can be used. I have some people who use even progesterone cream that's provided by their compound pharmacy. Sometimes we can even up the amount of medication that they're on it at baseline during those few days that they have increased seizure. So again, there are things to target the time of seizure cluster for these women. Now, how about birth control in women who are taking seizure medications? This is a comprehensive list if you want either to take a picture, or it is also in my YouTube online. The slides are there about which medications you have to worry about. If you're on anything like carbamazepine, phenobarbital, primidone, phenytoin, felbamate, topiramate, benzyl or rafinamide, oxcarbazepine, 5-compound, clobazam. These are the medications that there is warning about that there would be contraceptive failure if they're only on birth control, the tablet. There are a bunch of other ones that they don't make the the pill fail. So those are anywhere from etosaximazarantine all the way down, valproic acid is one of them, lamotrigine, levetiracetam, and you see the list. Again, you have to know whether you belong to that list, and then in that case, the pill is not the answer. How about our patient? Let's go back to SP. She had contraceptive failure because she was on oxcarbazepine. Oxcarbazepine is a medication that induces liver enzymes, makes the liver work much harder, gets rid of your birth control, basically. So that's why she became pregnant. So the doctor who was treating her should have told her that with the birth control, you're going to have failure, and you should be on a second method. And usually we recommend a barrier method, so IUD, the intrauterine device. Now that could have also the progesterone release, or it could be just a regular IUD. But in both cases, that would be the contraceptive method of choice. Or if they are on birth control, the amount of estrogen in birth control should be more than 50 micrograms. Do you know how much estrogen usually is in the birth control? Less than 35, because the lower it is, the lower the risk of blood clots, the lower the risk of all those, like high blood pressure, other things that can happen. So basically, that's not a good option to go up on the dose of this estrogen. And what else can happen? You can actually worsen the seizures with higher amount of estrogen. So basically, although that is on the book, on paper, it looks like an option. It's not an option. The best option that epileptologists, and that's what we are, what I am, we suggest is using an IUD, and especially IUD that has a good hormone, the progesterone. These are some of the examples of the birth controls that can have more than 50 microgram or 50 or more estrogen in them. Again, not the best choice. Depo-Provera could be an option, but in that case, if they really want to use Depo-Provera for contraception, women with epilepsy should get more frequent injections. The injections are usually once every 3 months. In women with epilepsy, it should be once every 2 months. And then the progestin-only tablets, that's not an option for contraception in women with epilepsy. It doesn't work. Low-dose pills, mini pills, does not work. So copper IUD, or the ones that have the progesterone, Mirena and Scala, those are the ones that are available. there are certain medications that we have to be more careful about. One is Lamictal or lamotrigine. So if a woman is on lamotrigine, we always tell them the moment you go on any birth control or you become pregnant, let me know immediately. Why? Because lamotrigine level goes right down to more than half, like basically less than half of what it used to be. So if you have a level of 6, all of a sudden your lamotrigine drops to 3. As soon as you, like the couple of weeks into the pregnancy. And usually by the time that they find out, they don't tell me that they're pregnant, they just tell me that they have seizures, because that's what happened to the medication. So Lamictal is tricky. It's a good medication in women with epilepsy, but you have to make sure that they know the moment that you have any estrogen in your blood, with the birth control or with the pregnancy, this goes down and needs to be adjusted. Now, we talked about 24,000 of patients who have epilepsy. Women with epilepsy become pregnant each year. And the seizure frequency, the very first thing that I consult the patients about is that there are 3 things that may happen during pregnancy. There is only about 10% of the women with epilepsy who have some improvement in their epilepsy during pregnancy. So unfortunately, the 90% either belong to this category that have no change, so 55% have no change in their epilepsy, but about 25 to 30% of patients with epilepsy have worsening of their seizures. So it's regardless of the medication dropping or anything else, the epilepsy, because of the hormones, can worsen in about 20 to 35% of women with epilepsy during pregnancy. So, what are some of the causes of increased seizure? Discontinuing or lowering seizure medications. Sometimes people, when they refer, I'm a center of referral for the women with epilepsy, so I have a lot of patients who are referred to me because they're pregnant or because they're young and they're planning pregnancy. The very first wrong thing that they do is that they either stop their seizure medication or lower their seizure medication in the hope that it can have less harm for the baby, but actually it results in seizures that can harm the baby more. Sleep deprivation, the anxiety and stress that comes with pregnancy also increase estrogen to progesterone ratio, especially in the first trimester of pregnancy, can worsen the seizures. And the other thing is that the seizure medications can drop in the concentration. Why do they drop? Because they're cleared more rapidly through the kidneys. They can have impaired absorption in the body. The patient can have variable compliance with the medication, or the liver may work harder. The hepatic enzyme induction and during pregnancy may get rid of that medication or metabolize it faster. There is more dramatic reduction with lamotrigine. Remember that was the one that we discussed. Sometimes with oxcarbazepine, that's the trileptal, carbamazepine or tegretol, these are the other medications. Phenytoin, phenobarbital, and levetiracetam or Keppra. So these are the medications that we have to follow more closely in order. So lamotrigine is the one that is almost like every month. The rest of them is at least every couple of months. Back to our patient. Patient had reduced level of oxcarbazepine secondary to pregnancy, resulting in recurrence of the auras. So we had to adjust the medication. The moment she came, she went up from 900 twice daily to 1200 twice daily. Throughout the pregnancy, she remained seizure-free. And then after the delivery of the baby, we had to do stepwise reduction back to the baseline of the dose of the trileptal because we didn't want her to become toxic on that medication. The other question that I'm always asked is that what are the risks during the pregnancy? What are the risks of seizures or seizure medications? There are 2 categories of risks. There are some risks that are related to seizure itself. So the seizure can cause greater trauma to the baby, obviously, can result in premature labor, intrauterine growth retardation or low birth weight, Stillbirth is much higher risk in patients who have seizures during pregnancy. Miscarriage is a problem, and also the hypoxia to the baby as a result of the seizure, the suppression of the heart rate in the baby when the seizure happens. So there is twice higher risk to the baby from a mom that has seizure. There is also some outcome that is associated with seizure medication. Excuse me. So epileptic seizures in women with epilepsy by themselves, regardless of the seizure medication, the epilepsy itself, the seizures itself, can increase the risk of birth defects in the children. So there are 2 studies that show the seizure medications separate from the seizure medications can cause actually birth defects in mother with epilepsy in the children. And it can double the risk of birth defects, so that is something that we should be aware of. Also, uncontrolled seizures during the pregnancy can result in 10 times more either morbidity or mortality to the baby. So stopping seizure medication is not really an option during pregnancy when you have somebody who has uncontrolled epilepsy. So if stopping the medication result in seizures, then the seizures can have more harm than any seizure medication that we know of. The kind of birth defects that can happen in the babies in patients with epilepsy are what we call congenital malformation. So those are the mostly mid-face defects. So cleft lip, cleft palate, those are very common. Midline heart defects, spina bifida, that's when the neural tube doesn't close properly. Those are the kind of things that can happen. So those are the common things that can happen in up to 10%, less than 10% of patients who have epilepsy. There is also risk of developmental delay in children born to women with epilepsy, language acquisition problems, up to 6.2% in one study that followed those children. So when I counsel a patient who is planning to become pregnant, I tell them that pregnancy is a risky business. So when you become pregnant, in general population, even if you don't have epilepsy, even if you're on no medication other than vitamins, there is about 2 to 3% risk that the baby can have a major problem with the heart, with the brain, with any of the organs. So there's a 97% chance that a normal person will give birth to a normal child, and there is 2 or 3% risk that there may be a big problem with the baby. Now, in patients who have epilepsy, that risk increases to about 4 to 6%. So that means if someone flips the coin, 94% chance of having a normal, healthy baby. So that's a very, very good chance. So we never discourage a patient from becoming pregnant, but we have to follow very closely and make sure that we do the right recommendation. There is also a risk of certain medications that can cause spina bifida. Valproic acid has a 1 to 2% risk. Carbamazepine has about 0.5%. That's the Tegretol, that's the Carbotrol, Tegretol, all the combination of the medications that have. So how do we gain our knowledge about the risk of these seizure medications? There are a lot of pregnancy registries. The main one that I use is the North American Pregnancy Registry, and I encourage my patients as soon as they become pregnant to register, because with their next pregnancy they will have more information. If they want a second baby, at least they were a part of the research to find out whether these medications are safe or are not safe. These are so far the data that we have with valproic acid. It has the highest risk of causing congenital malformation, 10.7%. So basically, it's about 89% chance of having a normal baby, about 11% chance that it can affect. Phenobarbital, 6.5%, carbamazepine, about 3%, not too bad. And when you look at lamotrigine, phenytoin, and carbamazepine, the risk is almost comparable with the general population, right? So you have 2 to 3% general population, except for this one that can increase the risk of spina bifida slightly more than general population. We know lamotrigine has increased risk of cleft lip and cleft palate. That's a cosmetic thing that can, I'm sorry, I started really, really late, half an hour late. So I'm almost done. And the topiramate was moved to category D because they actually found that it's 6 times higher rate of cleft lip, cleft palate in those children. So since 2011, that is, you know, the categories, like the C is we don't know whether there's a risk, the D is we know for sure that there's a risk in humans. There's also the risk of developmental problem with the babies that are born. So there was a study that followed them and found about 1.4 to 6% risk of having learning disability or other IQ problem in those babies. And these were the risk factors. Being on Depakote or valproic acid was exposure in utero. Low maternal IQ, being on multiple seizure medications, polytherapy, and also having multiple seizures during pregnancy. Those were the things that resulted in having babies that have lower IQ compared to general population. So how about the newer seizure medication? Well, the absence of evidence doesn't mean it doesn't come through as evidence of absence. We still have to register with the pregnancy registries to have more information about those medications back to our patient. With her medication oxcarbazepine, so far the pregnancy registries have not found any alarmingly high risk, so she continued with that medication during pregnancy. She continued with folic acid, and she ended up giving birth to a healthy baby girl. The folic acid supplementation usually is about 0.4 milligram in general population. In epilepsy patients who are on especially multiple seizure medications, we try to use a higher milligram, 4 or 5 milligram, and that's based on a study by Wald et al. That he looked at all of the different studies that use the folic acid, and with that dose, with the 4 or 5 milligram, you had more than 85% protection against spina bifida. There is no specific study for patients with epilepsy. These are the studies in general population. Other pregnancy recommendations that these patients should be followed by both epileptologists and the high-risk obstetrician. They should have a very detailed level 2 ultrasound between age 16 and 20 weeks when they can actually tell the sex of the baby, but they can also check the anatomy of the baby. There's also amniocentesis, some blood tests, AFPs that can be done. So with all of them together, more than 95% of problems with the babies can be diagnosed before the baby is born. Other recommendation is that when possible, try to use the lower dose, the lowest possible that controls the seizure. Make sure that the patients, if possible, are on monotherapy rather than multiple medications. Close monitoring and adjustment of the seizure medication levels are important, especially with the certain medications that I talked about, that they change, they fluctuate. And there are some medications that we have to use the free level rather than the total level because that would be more telling of the actual amount of medication in the blood. The breastfeeding, everybody knows that the breastfeeding is the best thing for the baby. The breastfeeding reduces infant mortality, fewer infection, they boost the immune system, lower the risk of diabetes type 1, and they enhance cognitive ability in the children. So why not breastfeed? The recommendation is that at least up to 12 months of age, the babies should be breastfed, but some mothers are concerned because if they are on seizure medications, would it affect my baby? Would it cause trouble with the organs or trouble with the brain of the baby, causing poor suck, reduced feeding, slow growth? my recommendation usually is that if that baby was exposed to this medication throughout your pregnancy, they were exposed to much higher level of that medication than now that they're born. So the amount that is given to the baby through the breast milk is much lower than the amount that the baby is actually used to. So if there was no problem during pregnancy, there's got to be no problem during the breastfeed. There's an exposure index that should be less than 10%. That means the amount of medication that is transferred to the milk should be less than 10% of the total amount. There are certain medications that are more harmful because the exposure index is much higher, like phenobarb, like etosaximide and trimidone. But there are other ones that are listed here that are considered generally okay because the exposure index is less than 10%. So our patients gave birth to a healthy baby girl, continued to breastfeed up to 6 months after delivery. There was absolutely no problems. She had some more auras right after the baby was born in the postpartum, but it was due to sleep deprivation and the stress that was natural after the birth of the baby. After that, we put her on IUD with progesterone release, and then there was no further pregnancy unless she wanted. In conclusion, there are particular challenges that women with epilepsy are facing. So they need to be aware of them, and they need to be treated by physicians who are aware of all those issues. If proper recommendations are followed, most of these women give birth to normal children, and usually there's not a problem. And we need to raise that awareness also, not only in the public, but to the healthcare professional. Thank you so much for listening. Sorry I rushed through this.